had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together.
I know it's a hard time, but for goodness sake, it's the best profession in the world.
Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes.
Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box set's curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practising Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to Matflix now for the best video streaming from maternity experts.
These awards, as you
And good evening to everybody, and welcome to this week's Maternity and Midwifery Hour. This is season 16, can't believe I'm saying that, session 7, and my name's Sue MacDonald, and I'm the curator for the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour. And it's my delight to be chairing this evening's session, which is going to be really interesting. I always say that, but it always is. And we're joined by two wonderful speakers, and that's Professor Helen Ball and Stephanie Michaelides. And as we always do, and look how glamorous our speakers are and ready to share their expertise, which is fantastic. But before they do, let's put them on the spot and ask them to share a moment of the week. Helen, what's your moment of the week?
Well, my moment of the week happened this morning at 8 o'clock. And every morning, every weekday morning, I go for a swim in the local swimming pool. And when I arrived this morning, the pool was absolutely empty. And I got it to myself for my first 40 lengths of 60 lengths. So that was really, really unusual and fabulous, because having the pool to yourself just makes you feel so calm and serene, and the water isn't disturbed, and there's only you swimming, and it's lovely.
And nobody bump into?
No.
Do you know, I thought you were going to say you went swimming. You were going swimming wild swimming, because I know that's very trendy, and I was thinking it's a bit chilly for that.
I'm not that trendy.
Then you say 40 lengths, and I'm astounded and admiring of you. So no one's calm.
It's only a hotel pool, so 40 lengths is not as impressive as it sounds. It's not a full length.
I think it's fairly impressive. I think it wins today's special prize. And how about Stephanie? Can you compete with that one?
I've got a phobia about water, so I wouldn't dream of thinking of swimming. But anyway, this week, a friend of mine has given me a beautiful flower basket, a very nice flower basket, which is now blossoming, and the flowers are really opening up. And in fact, I got some flowers in the vase next to me, and the smell is really, really lovely. And it's really making you realize that summer is really here. I really love this time of the year, not only because the garden is blooming, but also because we have long days, and I love seeing the long day.
Fabulous. Well, that's a lovely moment of the week, because I think it's so nice, isn't it? Because we keep having a warm bit, then a cold bit, and we've just come through another cold bit, and then we've got sunshine. And I'm sharing our UK weather with our international audience, because I know we have some people from all over the world joining us this evening. So welcome to all of you. And thank you for sharing your moments of the week, Helen and Stephanie. Well, we'll return. I'm just going to do a very quick resume, really, and because just as I said earlier, series 16, we were born in the COVID pandemic lockdown #1 in the UK in March 2020, 5 years ago. And I think sometimes it seems a lifetime away, and sometimes it doesn't seem so long ago. But we were really keen at that time to have some provision for midwives, student midwives, anyone within the maternity services, including mums if they wanted to join us, really to share what was going on in midwifery and maternity and link up people well, because I think at that time we couldn't go to study days or conferences or festivals or anything. Really, the priority was work, keeping safe, keeping women and babies safe, and just keeping the service going. And it was a very hard time. And every time I say that, I think how fantastic our NHS is, and how fantastic the nurses, the midwives, the doctor, the whole team is, because they kept things going during that time. So a big thank you, actually, for anyone who was there then, and actually those of you who are there now. So well done, all of you. Now, I'm just moving seamlessly to say also, I mustn't forget, for those of you who are new to the Maternity Midwifery Forum, everything is recorded. So if you happen to have a little power cut or you had to rush off, don't panic. You'll get a link to this session and any other sessions you want to go to, really, and you can catch up at a later point. And I know there's a lot of people who catch up with the Maternity Midwifery Hour on a Friday morning at 6 o'clock in the morning, and next Tuesday also. So, you know, watch out for that. But we're also very keen on sharing. So if you find this evening interesting, which I know you will, do feel as though you can share with your colleagues and friends and other students, fellow students, because that's really important to share knowledge And it helps for me when I talk about something I've learned, it helps me cement it in my own brain. So it's a good way of learning. So that's there. And I ought to also do a little advert for Matflix, who look after all the recordings that we do. And you can access those through the Matflix subscription, either with your university or your institution, whichever you're in. Or you can have a personal subscription. It's not too expensive. About the price of a couple of cups of coffee, I think. But my health warning is that once you start dipping in and looking at some of the presentations, it can be really a bit addictive, and you can find 2 hours have just gone by when you've learned something new and heard something really interesting. Really good if you're doing revalidation for those midwives, and if any of you students are doing a particular project or dissertation, or if you just want to refresh yourself on some area of practice, because you can dip in and dip out, and it's really good. So I'm going now on to the little news feature. It's Pride Month still. I haven't seen very much in the midwifery world, but I think there's usually a march from the RCM, but I haven't heard about that. I might have to report on that next week. It was HQIP Clinical Audit Awareness Week last week. And there is a link on the resources, and this is a plug for me to remember to tell you about the resources that are available from this session and from any references or research that Helen or Stephanie refer to. It's there. Now, the spending review today from the UK government came out, and I understand there's more money for the NHS. And that always gladdens my heart, because I think we need as much as we can get. But I didn't get a clear idea personally about the details around how it was going to be spent, apart from increasing technology and digital transformation. When people start talking about millions of pounds, I kind of lose and think, well, what does that actually mean in my maternity unit? But I know that Neil Stewart will be writing a wee article for next week, and I suspect that he'll find a little bit more detail for you. And there's also, I need to refer to, because I haven't talked about this for a while, and that's my little calendar. This is from Action from Happiness. Again, that's on the resources. Really nice for those of you who are interested in just having a nice thing to do each day, something mindful to think each day. Quite positive, because especially when it's busy and it's stressful, it's good to have something just to ground yourself. Now, you see, last week it was take a photo of something that brings you joy and share it. And I thought it was lovely, but I didn't share it last week. So I'm sorry about that. This one is quite simple for all of us. Maybe eat good food that makes you happy and really savor it. Now, that means trying to avoid that old super processed food. You know what I'm saying anyway. So, and tomorrow is write a gratitude letter to thank someone. So it's all those sort of things that you could sort of fit into your normal life, which will give you some pleasure and some lightness, and also will pass on a bit of happiness. So that's my thing of the day. Now, we're going to, I'm almost perfect timing, and I'm always very keen that my speakers have as much time as possible, because it's going to be really interesting. And I know both Helen and both Stephanie have been trying to twist my arm to make this hour longer. And we know that this hour is the quickest in the week, but they can't have any more time than we've given them, can they? Anyway, this week we're going to be looking a little bit more at the baby. And we've said it's about how babies sleep, but we're going to start off a little bit more of looking at the normal baby and some of the things we need to think about as we're talking to the mum and we're looking at the baby and assessing the baby. And who better to bring in would be Stephanie Michaelides. Now, I want to say a huge welcome to Stephanie. She's a midwife, she's a neonatal nurse, she's an educator. She's got a huge history of practice and teaching and in nursing and midwifery. And she, as many of you will know, pioneered the development of the first examination newborn course in the UK. It's often used as a template for other courses. And one of the things that she is passionate is about the neonate. And I've learned so much over the years from Stephanie about the newborn and the language of the newborn. And it really makes a huge difference. You will learn a lot from Stephanie. Now she's learning she's also learning because I know she learns as well every day. She's working as a midwife education consultant at the University of East London, and you'll see that from her CV, which this is a cue for me to say, both speakers' CVs, a little bit longer, are online, so you do have a look at those. Stephanie's been an advisor to national and international bodies centred on improving care for the newborn, including the sort of NIPE. I'll say NIPE. I bet Stephanie will mention NIPE in her session. So welcome, Stephanie. Thank you so much for coming this evening. The screen is now yours.
Thank you, Sue. Thank you very much, Sue, for that introduction. And hello, everyone. This talk is just 15 minutes, which I hope will stimulate questions in the chat that I can fulfill the depth of knowledge that you all require, because I'm only able within 15 minutes to cover a summary of points. The transition to postnatal life is the most difficult journey every one of us takes. And it depends on, for that individual baby, how he copes. And it is stressful, whether it's vaginal or instrumental birth. Following birth, the baby will gradually transition from his life dependent on the placenta to independent life. It's important to recognize that the baby's each system at the point of birth is immature. Oh, sorry, just a second. Can you see them now? Angelo, can you see them? Okay. Sorry about that, folks. You think as a teacher of X number of years, I would know how to use Zoom, but hopefully you'll understand. Following birth, the organs of each baby it's immature. They don't all develop at the same time, and they take time to develop from birth up to days, weeks, and months. The first assessment of transition of the baby is the APGAR score, followed to validate transition at 1 hour of age. Within that time, within that hour, that baby, we need to recognize, requires to be given time, minimal handling from us, but time with his mother to promote maternal-infant interaction. That can be supported through the use of safe skin-to-skin care. And I say safe skin care because, as we know from BAPAM, they have advised for the first hour for a midwife to stay with the mother, not only to support the breastfeed, but also to support that the baby maintains an airway within that first hour because of the rise of postnatal collapse that we've had in the UK. That means making sure that the baby's nose is free and that the baby's chin is away from his chest in order to maintain air into the lungs. This is also the best time for the baby to get to know his mother and to have the first breastfeed, because they're wide alert and ready to feed. And this first feed may be required because the rest of the time, the rest of the 48 hours or so, the baby may be spending sleeping. Then we come to the 1 hour assessment. That 1 hour assessment is far more important today with the knowledge we have, because when I first trained, we just did the CIRC, reviewing that there wasn't any visible congenital abnormalities, to the basic observations, and that was it. The baby then went to the neonatal unit. Now the assessment is encompassed within the SEN examination, which I'm going to talk about, because that first assessment would dictate how soon the next assessment will require to be validating the normality of transition. An important aspect of the assessment of each baby is the history that we undertake. Lots of history, but the most important history that we actually need to have is from the mother, to get her history. And the importance of communication with parents who speak English is for us to make sure that we utilize the correct words for her to understand and give us the answers that we require. But also it's vital from different reports, including the Embrace recently, who talk to the fact that when mothers do not speak English, we need to use the language line and interpreters to enable us to communicate effectively. The systematic examination of the newborn, as all of you know, since the 2019 has been introduced into the pre-registration training of midwives. And as And also we have the NICE guidelines, who have also in 2021 produced a detailed assessment of what the top to toe assessment should include. And we also have NIPE. NIPE is the newborn infant feeding examination of the baby. Now, the difference between SEN and NIPE is really quite clear. That each area of the baby will need to be assessed as part of the SEN. And it involves the neurobehavioral physiological assessment. And the physiological part of this assessment is looking at each system based here on the orange. And you can see it's all the system that the baby's, all the organs that the baby has, which need to be assessed and validated as part of the SEN. And midwifery students learn in the first, second, and third year. The NIPE, the very important part of the SEN is a continual assessment. If you look at what NMC is stating, is that we need to assess the babies from birth to the continuum. They don't actually say weeks or months or whatever it is, but it's taken to be from birth to 6 weeks. And it's a continued assessment. It's not a one-off. However, NIPE is a one-off assessment undertaken within 72 hours. This NIPE assessment forms part of the SEN assessment. It is not separate. It's very important to realize that the NIPE, which includes eyes, heart, testes, and hip, is assessed at that moment in time. And it's important to recognize the limitations of NIPE, because although you assess the heart, say, for example, and you validate it as normal, our knowledge of physiology informs us that the heart cannot be assessed as normal until the baby's ductus arteriosus closes, and that can be anything from 48 hours to 10 days, and that means continuous assessment. Whereas the SEN will continually examine the baby in hospital and continue that assessment in the community. It also involves the hearing, and hearing is part of the assessment. So if we are undertaking the 72 assessment, not only do we undertake the SEN, and which includes the NIPE, but we also need to make sure that the hearing has been undertaken. Each baby has his own individual needs that support and inform us of how the baby's doing. Utilizing his neurobehavior and physiology will help us assess that baby. And it's very important to recognize the knowledge that we have of the neurobehavioral physiology of that baby is what makes that assessment safe. Minimal knowledge, that assessment is questionable. Depth of knowledge will make sure that each assessment will provide safe assessment and care plan for that baby. Each part of the assessment involves each organ. For example, the respiratory organ consists of observation, palpation, and auscultation. And it's important to recognize that the most important part of all is observation. I know as a teacher and the beginning of teaching examination for many years, the one thing that everybody heads for when they assess, say, for example, the heart, is they go for the stethoscope. And I have to tell you, the stethoscope will give you far less information regarding the cardiovascular and many other systems than the actual palpation and observation of the baby. We need to make sure that we recognize this fact and stand back prior to each assessment and observe that baby. For example, me looking at this baby and him looking back at me, I can more or less validate all the systems on one go and recognize that this baby is well and not stressed, to allow me to continue to assess that baby. If the baby becomes too stressed, I need to make sure that I discontinue the assessment and start it off at another time. Not only do I need to learn and understand the baby, and I have done so over many years of handling babies, but I need to share that knowledge. And I can't share it by teaching in the classroom or asking students to learn it from books, however brilliant the books may be. That experience needs to be gained by the individual students. And one of the best ways to teach students to handle and observe babies, well, to observe babies mainly, is to allocate them 10 minutes, minimum of 10 minutes each day, to just sit and observe the behavior of the baby. This repeated experience will add to the strength and knowledge of that student at the end of their training. Some of you may already know, but one of my favorite pediatricians was Brazelton. And Brazelton was a pediatrician who did an awful lot of work on the assessment and behavior of the baby. And he was there really to help parents understand the baby, but it also helps us clinicians also to make sure that we understand how to handle babies. Here you will see 6 sleep states, which he developed to let us support the care of that baby and to produce appropriate actions to meet their needs. If you look at this, the baby has 6 sleep states. The sleep state 1 and 2, the baby is in a sleep state, deep and light sleep, and then it wakes up to 3 and can go to 6. What he has actually taught us and what I have utilized over the years is to recognize that handling babies in sleep state 1 and sleep state 2, within a few minutes of handling them, if we don't do it gently and wake the baby up to sleep state 3, the baby will go into crying state. So therefore, we must be able to recognize sleep state 1 and 2 in order to wake the baby gently. And to do so, we stroke the baby once or twice, very gently, and talk to the baby, and then remove the blankets very gently, and allow the air to get to the baby, and you will see the baby starting to move. And the baby then will allow you, as that baby previously did, to go ahead and examine it. If we don't do that and we go up to the baby, remove the blankets, pick the baby up, take it to the resuscitator, it very quickly will go into sleep state 6. And the baby's neurological system is very immature, and it's up to us to utilize our knowledge by limiting the baby's arms and legs and getting have eye-to-eye contact through talking to him or her to enable it to calm itself down. And also by doing so, we'll be able to get it back to sleep state 4 or 5 in order to complete the examination. Not only do we need to understand that behavior, so does the mother. It is vital that the mother understands this, because one of the things that we do quite a bit is to ask the mother to wake the baby up every 3 hours to feed it. It's important for her to understand how to safely, the information I've just given you needs to be shared with her, so she doesn't actually think because the baby's crying is because it's rejecting her. It's probably she didn't really know how to recognize the baby in sleep state 3 before she actually picked it up. Second thing that we need to ask ourselves is, why do we actually need to feed the baby 3 hourly? A baby of 1 hour who's been assessed to be normal and exclude the risk of hypoglycemia will only require the colostrum to develop his GI tract. He doesn't really need to have actually calories, because the colostrum will only provide some. The rest of the calories the mother has provided for the baby during the 3rd trimester, but the provision of adipose tissue in his buttocks and thigh. And this baby will then utilize ketones and lipids to support it while the baby isn't having any enormous calories in the first 2 days of life. We actually assess babies 3 hourly because we are asked to review the baby in transition. If you left the baby more than 3 hours and that baby's transition isn't progressing normally, and say, for example, the baby is infected, it will stay sleeping and it would not alert to the mother, would not be alerted because the baby's sleeping, she will leave it in the cot. Asking the mother to feed the baby 3 hourly, and we also for us to review the baby on 3 hours to validate that he's well and instigate management if he's not. We need to make sure that the mother also recognizes that the baby utilizes the breast not only for food, but for non-nutritive sucking. And as I said, birth in progress is quite traumatic for the baby if it's for some births, especially some of the instrumentals. But also if the baby is vaginal birth, depending if it's been in long labor, there would also be stress. And they can use sucking to support. And the mother's story normally is, Stephanie, my baby is continuing on the breast, and as soon as I put the baby down in the cot, he cries, I don't have enough milk. Could you please give me a bottle? It's important for us to share in a sensitive way to the mother that the baby doesn't just utilize the baby for food, but also utilizes a breast to relieve the pain or the stress, depending on what is causing the baby to be so irritable. And it reduces that because pain, when the baby is sucking, does not travel up to the brain, and it's blocked at the bottom, at the base of the spine. So therefore, as long as the baby is in discomfort, he will utilize to relieve the stress through sucking. Now, the mother who's just had a long labor needs to get some sleep, as the baby needs the sleep. So in incorporating the father to utilize his small, clean finger to provide feed to the sucking to the baby would then fall asleep and the mother would get some sleep, and both will be happy for it. However, it's important to recognize nothing is normal. We only validate normality through assessment of that baby. And if the mother has concerns because the baby's sleepy, We need to examine that baby to identify whether he's sleepy because he's recovering from birth. Babies who are stressed use sleep to recover from stress. However, the other baby who is stressed is the baby who I've just mentioned, who is very, very irritable and crying all the time and requires to suck. We need to identify, is it just recovering from the stress of birth, or is it actually have some form of a trauma, such as a fractured clavicle, which needs to be treated? And that can only be identified, normality can only be identified through the assessment of the newborn. If the mother is to choose to artificially feed, my support needs to be the same as I give to the mother who's breastfeeding. And I need to stay with that mother in that first hour to observe that feed, to exclude that the feed is not causing any problem to the baby, such as in having a congenital abnormality, such as a tracheoesophageal fistula. So therefore, the first feed is given with me being present. I need to make sure, though, however, the baby who is breastfeed can go to the breast immediately following birth. However, the baby who's artificially feeding cannot be given a feed until 1 hour when the baby had the top-to-toe assessment to validate whether he's well or not well. A baby that is sleepy or has respiratory problems will not be able to coordinate sucking, swallowing, and breathing, and may lead to aspiration of the milk into his lungs. We need to make sure through our assessment that the mouth is intact. And in this slide, you will see the spatula showing the baby having a cleft. I've showed this slide because one of the things that we're talking about, validation of the mouth, this will be done at 1 hour, not at 6 hours or 12 hours. We need to do it before the baby has an artificial feed in order to make sure that the baby can take it safely. The other thing I've got here to show is we no longer put a naked spatula in the baby's mouth. The spatulas today needs to be covered. Either we use a plastic one or one that is in a plastic glove, because our finger should be at the end of the spatula, because the people who are already doing this will recognize how strong that tongue is, and it can be lift and split the spatula apart. So it's important to use that mechanism safely. It's important for the mother to also recognize how immature this GI tract is, and the importance not to overfeed the baby. And in the first 24 hours, the baby should only be having 50 mils in the bottle and be given over a length of time to make sure that we do not overfeed the baby. Because the baby who's artificially feeding would also use non-nutritive sucking. And if you give it a full bottle, he will empty the bottle in no time, not because he's hungry, because he's using it as non-nutritive sucking. Then once we started artificial feeds, we need to make sure that the baby is tolerating feeds and the GI tract is intact. And for both breast and bottle feed babies, we need to look at the vomit. Babies all posit. It's physiologically normal for babies to posit. It's a safety mechanism. And the baby, as long as they're clear, we do not worry. Green vomits is an emergency, and we need to refer the baby as quickly as possible to the doctors. Meconium. Babies can pass meconium. It doesn't mean the anus is patent. We need to make sure that we can identify by looking at the anus and obtaining an anal wink. A sick mother means a sick baby. I urge everyone who has mothers in the high dependency unit not only to monitor the mother, but to also put the baby on observations. We need to avoid separation of mother and baby, because Attain has shown us how it affects breastfeeding and interaction of mother and baby. We also need to make sure throughout the postnatal period we review the baby for any delayed maternal-infant interactions to see if there's any problems, because that might be the first hint to recognize a postnatal depression. In this picture, you see a lovely baby smiling at his mother. It's important to recognize that is the normal progress of babies. If a baby at 6 to 8 weeks does not smile, the doctors then review the mother for postnatal depression. That's been given by Barbazidone and others. We are only with the mother for a very short space of time, and our mothers in London stay 6 hours, 8 hours, very soon in their home. We need to make sure that in the antenatal period, we introduce what NICE guidelines have advised us to do, is the scoring system obtained through the Lullaby Trust, which helps parents to recognize any concerns they have to whether they need to call their midwife, the doctor, or take the baby into accident and emergency. If we miss the antenatal period to educate the parents, We need to take the next opportunity given to us while the mother's on the postnatal ward, and we need to instigate, if we don't already have them, postnatal workshops to provide assessment of that baby to that mother. And it's important that that talk is being given by someone who has been trained and has got the experience of SEN. When we finish the contact with baby, at each time we come in contact with the baby, we need to recognize whether we're dealing with a well or not well baby and ensure the appropriate assessment to do so. We need to ensure that the parents understand our findings and also what the follow-up will be on that baby. They are the safety net. We may go off duty, but the mother would know what her baby and when it should be seen, and will make sure that that does happen, whether it's hospital or community. We need to make a plan and record that plan, and also utilize appropriate red book if the baby's in the community. Record keeping isn't just our legal support, it's also a way of communicating to our rest of our professional team to provide continuity of care to the baby. If the baby does not meet the normal criteria, we need to be confident to articulate our referral to the appropriate professional and make sure that senior the registrar, and if we're not happy with the decision made by the registrar, we are advocates for that baby. We must insist that that baby gets seen by a consultant. Take-home messages are very much of what I've said. Normality for the baby, unlike the mother, is a diagnosis from exclusion. We need to exclude abnormality of the area that we're examining to validate normality. For example, a long-term prolonged jaundice, for instance, can be deemed to be perfectly normal in the majority of babies. However, we cannot validate normality for that baby unless we screen to exclude conditions such as hypothyroidism or biliary atresia, which needs to be identified within 6 weeks of life. The newborn baby in the first 48 hours has yet to form a behavioral pattern. The baby in the 48 hours is very erratic in what he does, how often he feeds, when he feeds. He will feed maybe in the night, but not feed during the day, or he feeds at 10 o'clock and will not feed at 11 o'clock or 12 o'clock. So they're very erratic in their behavior. Recognizing the normal behavior and excluding the abnormal will support the newborn's development. In summary, practitioners who care for the neonate require not only the ability to perform and organize, and I truly mean organize, systematic assessment, thorough assessment of the baby, but also required to have the knowledge to understand and recognize normal and abnormal findings. Early recognition and serial examinations will allow the deviations from normal to be recognized and allow for reduced morbidity. Thank you for listening.
You sneaked a bit of extra time there.
No, really, I thought I was.
Yes, you did. But I think we might just run over a little bit. But for those of you watching, if you have any questions for Stephanie, please put them in the chat box. And then after Helen's done her presentation, we've got a little time for discussion. So I'm really delighted to introduce and welcome Helen Ball, Professor of Anthropology and Director of the Durham Infancy and Sleep Centre. And Helen studies infant sleep and the parent-infant sleep relationship from a biosocial perspective, including sleep ecology. I love that, the sound of that. I want to know more. Of infants, young children and their parents, attitudes and practices regarding infant sleep, behavioural and physiological monitoring of infants and their parents during sleep, infant sleep development, and the discordance between cultural sleep preferences and biological sleep needs. And she's done loads of research in hospitals and community and has contributed to national and international policy and practice guidelines on infant care. She also pioneers the translation of academic research on infant sleep into evidence by use, and this can be used by parents. And there's a basis, it's called the BASIS Baby Sleep Information Source website, and that link is on your resource sheet. She's also been an editor, author, and she's won loads of prestigious awards, including the Outstanding Impact in Society from Economic and Social Research Council, which is very prestigious, and the Queen's Anniversary Prize for University of Durham. So welcome, Helen. Thank you so much for coming this evening. The screen is now yours.
Lovely. Well, thank you very much. Hopefully you can see my slides on the screen now. And one of the things that Sue didn't say that I'm going to start with is to just let you know that my new book, which came out at the end of May, is called How Babies Sleep. And I'm going to use that as a springboard for the talk that I'm going to give you this evening. And I'm going to talk to you about two aspects of baby sleep, two ways of thinking about what's happening with baby sleep. And these are two of my favourite bits in the book, really. So in chapter 1, I talk about the nature of babies, and Stephanie's already given us a good introduction to the nature of babies, but I think about babies' biology in a much larger scale from a kind of evolutionary perspective. So how is that helplessness of babies that we see in the newborn phase, where does it come from? And one of the ways in which I summarize this in the book is the unique suite of characteristics we've amassed over our evolutionary past has resulted in human babies being the most helpless of all primates at birth, completely dependent upon caregivers for warmth, safety, food, for the entire first year of life and beyond. So let's think for a minute about what that means. Human babies are mammal babies, and we're born with a set of inbuilt needs that our parents have to provide for us. And a lot of times it's the breastfeeding parent who has to provide meet these needs. So there are two types of mammal baby. They tend to be divided into species that produce altricial babies and species that produce precocial babies. And altricial babies are born in a really undeveloped state. They're hairless at birth, they can't see, they can't hear, they can't call. They're sequestered in nests. They're usually born in litters, so they stay in the nest with their siblings, keeping each other warm, and basically they sleep and grow. And their mothers leave them for long periods of time. They go and forage so they can produce lots of milk, and then they come back and they feed their babies. And they feed their babies with milk that is high in fat and satiates those babies for the next long period while the mum is off foraging again. So examples of altricial babies are things like these squirrels, mice, hamsters, rabbits, kittens, puppies, all of those animals that you know that produce large litters of undeveloped babies. The contrasting group are what we call precocial babies, and precocial babies stay close to their mother. Their mother provides them with safety and warmth, and they feed often because their mother's right there. So these babies have a longer gestation period. When they're born, they're much more well developed. They can see, they can hear, they can call, they can stand up and follow their mothers, or they can cling to their mothers and maintain their own proximity with the mum. The milk that the mothers of precocial species produce is low in fat and it's high in energy. They don't need to be satiated. The babies don't need to be satiated for long periods because they can feed frequently, but they do need energy. And they need energy for either following or clinging to their mums to maintain proximity. So if we think about human babies, then human babies have got this strange combination of traits at birth. They're precocial, but they're uniquely helpless at the same time. So we produce single babies that have got well-developed internal and sensory organs. They can see, they can hear, they can call at birth, therefore they meet the criteria of being precocial mammals. And we as mothers also produce milk that is low in fat and high in sugar, and our babies need to feed frequently, so that's another precocial characteristic. But our babies have got really poor neuromuscular control. They're unable to stand and follow, they're unable to cling, and they can't do these things, standing and following, they can't even do for the first year. They've got the grasping reflex, but they don't have the strength to cling and to coordinate, kind of hanging onto their mother's bodies. And again, that takes multiple months to develop. So human babies have got poorer coordination than other precocial mammal newborns, and they're helpless. And all of this is to do with the fact that their brains are undeveloped at birth. If you think about the amount increase in size of a baby's brain between birth and 1 year of age, what human babies are doing is spending their first year of life growing an enormous brain, and that needs energy, and that is what the mother is providing in that high sugar, low fat content milk. So night waking and needing contact are normal behaviors for human babies. Babies finish gestation outside of the womb while their brains continue to grow rapidly. And during that time, because they're so helpless, they need close contact with a caregiver for warmth and for security and for biological regulation. Babies' biology is much more stable, their breathing, their temperature, etc., when they're in physical contact with a carer than when they're separated. Human babies need their caregivers day and night for many months. When they're born, they don't have a day-night rhythm. They sleep around the clock, and they don't sleep for long periods. So frequent night waking and seeking contact are biological needs for baby humans. So what this all means for sleep then is that as growing a big brain is energetically expensive and brain growth tends to happen during sleep, we should expect human babies to sleep a lot. And because babies wake and feed at night, which is an important driver of their mother's milk supply, we should be expecting human babies to need to wake frequently in the night. It's an important behavior for them, and we shouldn't try to suppress their night waking. And like other precocial infants, human babies expect close contact for warmth, for safety, for food, day and night. So we should expect that human babies want to be held. They feel most able to relax, they feel most comfortable, they feel most easily able to fall asleep when they're safe and warm in the arms of a caregiver. And around the world, this kind of way of taking care of babies with constant contact is the norm. But in our society, what people have sometimes called weird societies, Western societies are sometimes called weird, which is an acronym of Western, educated, industrialized, rich and democratic, a thin and unusual slice of humanity, according to the author who invented the acronym. What we do with babies is weird. Our cultural expectations about babies' sleep can often be very unrealistic, which makes caring for a new baby really challenging. There have been huge changes in Western society over the last 100 to 150 years that have impacted families and have impacted baby care to a huge degree. And a lot of that happened as a result of industrialization around the end of the 1800s and the beginning of the 1900s. And since that era of industrialization, where many people went from kind of agricultural lifestyle or a small town lifestyle, market sort of economy, to working in factories and mills, parents had to learn to cope with their baby's helplessness, their baby's lack of a day-night rhythm, their baby's night waking, while their own sleep was being regimented and compressed into an 8-hour window due to the demands of the workplace. People would be working 12 hours a day. They would have little time to sort of take care of their needs and their baby's needs. And their baby was expected to conform with the needs of adult life. And early 20th century experts, if you go and read the books and the things that they were writing for parents during that time period, advised managing babies' sleep patterns in a way that meant disregarding those babies' needs at night. So you all have heard these sort of sentiments, sayings, folk wisdom about how you should take care of babies at night, such as babies aren't in charge, we need to show them who's boss, don't respond to them at night, learn to make them wait, crying's good for their lungs, picking them up too often will spoil them, don't let them feed to sleep, cuddling makes them clingy. And all of these kinds of things were born of that era when parents were being encouraged to sort of manage their babies at night in such a way that they wouldn't wake them, or they would wake them minimally. So I've written about this in an article that came out very recently in The Conversation. It came out on May the 29th, so hopefully we can put that in the resources for you, because I've summarised some of what I talk about here. But the second topic that I'd like to share with you this evening is about bed sharing. And this is also one of my favourite topics about baby sleep. It's really where my research got started. So in chapter 6, where I talk about bed sharing, I say, I wanted to lift the veil of stigma that was draped over the topic of bed sharing and explain to the critics and the uninformed why it was important for many families and why expectant parents needed to know about it, to have opportunities to discuss it with others, and to learn about its benefits, hazards, and nuances. So in thinking about why parents in our weird societies end up sleeping with their babies, there are numerous resources that we can draw on, but one is a systematic review that was conducted in 2014 that found that bed sharing, parents bed share for numerous reasons, but the top reasons that parents give always involve breastfeeding, comforting the baby, the fact that it helps them to get more and better sleep, the fact that they can monitor their baby more easily, and they feel more bonded or attached with their baby. But breastfeeding is always the most common reason that comes out in these studies. It's described by mothers as easy and convenient way for managing frequent nighttime feedings. It helps mothers to preserve their sleep, especially when they're returning to work. And so I was really interested in what was happening in parents' beds with babies at night when I first started this research. And we did a series of studies where we videoed mothers and babies and sometimes dads sleeping together at home, in our sleep lab, and on the postnatal ward of a local maternity hospital. And what we found was that breastfeeding bed sharing mothers sleep together in a very characteristic way. Babies are positioned flat on the mattress at the mother's breast height. They're on their backs. The mum curls up around the baby with her body, making a space for her making a space for the baby to sleep in, with her arm above the baby's head and her knees underneath the baby's feet, meaning that the baby can't move around the bed. They can easily breastfeed, and the mother can easily check on the baby during the night. We've also found that when mothers and babies bed share from the early days, that facilitates breastfeeding. So this graph shows a study of over 1,000 mums that we followed up from the postnatal ward to 6 months, looking at their breastfeeding journeys. All of them were breastfeeding when they left the hospital, and we contacted them every week and asked them whether they breastfed their baby, and we asked them whether their baby had slept in their bed. And those families who did not have their baby sleeping in their bed in the first 13 weeks, their breastfeeding dropped off quite dramatically. And by 6 months of age, fewer than half of them were still breastfeeding. Whereas the ones who did have their babies in bed with them, their breastfeeding dropped off less dramatically, and twice as many of them were still breastfeeding at 6 months. So it both helps mothers in making nighttime breastfeeding easier, but it also facilitates the maintenance of lactation by having that frequent feeding happening during the night. So because of all of this, it was very important to me to make sure that all parents knew about how to bed share safely, not just breastfeeding mums, but all parents, because we know that the vast majority of parents, whether they breastfeed or not, will bring their baby into bed at some time or fall asleep with their baby accidentally at some time. And everybody needs to know about what makes it safer. Breastfeeding moms are more likely to bed share frequently, but all parents will end up doing some bed sharing. So the Lullaby Trust guidance, and it was great to hear Stephanie also referenced the Lullaby Trust earlier, but the Lullaby Trust guidance that came out in 2018 makes it really clear to parents what the situations are when they shouldn't bed share and how to bed share as safely as they can if that's what they choose to do. So a few take-home thoughts then. Human babies have needs that don't easily fit with contemporary adult life, and the hormonal and neurological processes that regulate babies' sleep develop slowly over the course of the first several months. Prolonged and deep sleep isn't normal in the first few months of life, and we shouldn't be trying to encourage babies to do that. Many families, particularly breastfeeders, manage normal baby sleep disruption by bed sharing, and breastfeeding mothers cuddle curl to reduce risks. Bed sharing helps them to breastfeed for longer. But all parents need information on bed sharing safety and contraindications, and realistic expectations going into this phase with a very helpless newborn baby human is that we need support. We need support from family and friends, and we need honest information from well-informed professionals. And I'll stop there. Thank you very much.
So much, Helen. That's really interesting, and a sort of a different perspective on babies as a creature, a little independent creature, and I think the being reminded about how we're trying to control the babies, and the mothers and the families are also pulled into that, and that's all come from industrialization, is really a useful reminder. Because I think the other thing I guess is that these days people like to control things more. Do you think that has a feature? Have you met that in some of your research? Because I know
definitely
younger.
Definitely. Yeah. Some of the most anxious parents are the ones who really would like to be in control of what's happening with their babies, particularly at night, and then struggle with the fact that their baby doesn't conform to the sort of the expectations that they had about how they were going to take control. I mean, there are ways in which you can sort of gain some control by modifying the way you think about things and relaxing and just going with the flow. But if you want to sort of have a clock-driven schedule and get your baby to go to sleep at a certain time, and your baby's biology is not kind of congruent with that, it's going to cause all sorts of difficulties, and that's going to be really frustrating. Yeah.
And I guess not going to help with the mother's sleep, because of course, I mean, and I'm just thinking, you hear mothers of mothers saying, "Oh, well, is he sleeping all the way through now? Is he being good?" And these sort of little
those ideas, come from a historical past when having a good baby was the purpose of parenting, and that meant you were a good parent. We know a lot more about that now.
It's a bit of a struggle, isn't it? I think we've got a comment from Maeve O'Connell. Thank you, Maeve. How are you? And she says, "Thank you so much. Fascinating presentations. Really enjoyed them both." Hasn't come up with a question, because I think you've possibly, Helen, I think possibly both of you, and I hope Stephanie's going to unmute herself in a mo. Both of you have actually given quite a lot of food for thought, and I know both of you have given an enormous amount of information for people to think about this little newborn baby, and how we look at the baby, and we look at the parents, and how our whole, as midwives, our whole being is trying to make sure the mother feels more confident, but then we have to do this first initial assessment to make sure the baby's well enough to do all the things that the mum is thinking. And I'm not sure. What did you think, Stephanie, about this little creature that's the baby? And in the
Stephanie's the baby very well.
What is it that you want me? What is it you asking? Sorry, Sue.
Well, I was just thinking, because it's a different. I think what was fab about Helen's session is it's a different way of looking at the mother and the baby unit, or the mother and family unit. I specifically like the weird
acronym.
Because that's very much a Western thing, that we're trying to kind of control this poor little baby, and we're fighting against nature. So how on earth are we ever going to win? And I'll give that question to Helen first. How can we win in this battle where we're trying to fight against nature, and this poor little child is just trying to be a baby, a helpless baby?
So my answer to that question has always been that we need to normalize what being a newborn baby is like, so that parents don't have unrealistic expectations and they're not fighting against it. I think you can accept the needs of your baby and aim to meet them. They change. I mean, one of the things that's really important about thinking about babies' biology is that over that first 6-month period, they change hugely in terms of their abilities and what they're able to do, the way that their sleep changes, the way that their feed frequency changes, the amount that they can take at every feed changes, so they're not these static things that you sort of get into a routine, and that routine will stay there then for the next 6 months.
Right.
It's a very dynamic process, isn't it, looking after a baby? And I think letting go of some of that need to control that and responding to what your baby's showing you it needs and it can do, I think is quite liberating for some parents who feel as though there are all these rules that they've got to adhere to. If you can kind of strip away some of those cultural rules and look at the baby's biology, and how to meet their needs at any given point, I think it makes it actually a lot easier.
I think we'll Stephanie start off by saying this new baby, because that illustrates really well how the baby does change, doesn't it? Because initially that baby's very not uncontrolled. What's the best word, Stephanie? When they're just a bit, you can't rely on what they're going to do.
I think knowing babies and really recognizing their history and what the age and gestation of that baby can help you understand what they do. The newborn baby is very unpredictable, as you say, but to a certain respect, there are certain things that you do expect to identify and see, and not recognize much of what the baby does is built in within. For example, I always consider the baby when he's first born, the miracle of that baby taking the first breath. How babies change from being in utero to postnatal life is amazing. The triggers and the changes that need to take place for that baby to breathe are fantastic. I think we need to, for the mother to feel in control, we need to start thinking about educating the mother about her newborn baby before the baby's born. I think sometimes we concentrate on birthing experience, labor, rather than what the baby will be like. Because many mothers, we call this word bonding, and we say that the mother will bond. I don't think all mothers bond with the baby. Some would, but mothers need to learn to interact with the baby. And the first time they meet that baby, they need to really have some understanding of what he's going to be like. Otherwise, that baby controls the mother rather than the other way around. And the more she understands the baby's behavior the way we have learned to understand it, the more in control she will feel right from the beginning of the baby. So either in antenatal period, which will be the best time, or in the postnatal, we need to increase our education of that baby's behavior. Brazelton has compiled a brilliant course that midwives and other professionals can take for parents, to be teaching parents how to understand the behavior of the baby and learn to enjoy being parents rather than being frightened of being parents.
Yeah,
I think that's a really important point. Yeah, learning to enjoy being parents, I think, is very important. Yeah.
And I suppose it's understanding the baby as an individual rather than this little thing that's just part of the mum, isn't it? I suppose. No, it's really, there's a whole lot of things coming through now. I think people are commenting. I think they're just bowled over by what you've been saying. So Maeve,
they needed time to think. I think.
I think so. Well, we can have questions on this later if people would like. Maeve says again, love Stephanie's reminder to check the patent anus and the newborn mouth. Okay, and then Carol Goddard, hi Carol, says love both presentations. Thank you very much. Maeve comes back. Hi, Maeve again. Helen's perspective was really reassuring as a new mum. We're terrified of SIDS, sudden infant death syndrome, and it's hard not to co-sleep when breastfeeding. And I love this cuddle curl. What a wonderful phrase. Well, did that come out of the research, Helen?
We called it the protective C position, which was a bit of a mouthful. And somebody else came up with cuddle curl as something that they'd read about in the literature on dogs. That dogs do a kind of cuddle curl, and applied it to what we'd observed. So some people call it the C position, and some people call it a cuddle curl.
Yeah, I think cuddle curl is lovely, and I thought what the images you shared were fabulous because it really looked so protective and safe, actually. And I know that, and Stephanie will be aware of this as well. The Royal College of Midwives did some guidelines for co-sleeping for parents, based very much on what you were talking about, Helen, and making sure about not having smoking and drugs and everything. Yeah, being in a safe place, because actually a bed is probably safer than a sofa.
Oh, much safer.
I would think, yeah. And that illustrates it brilliantly. Okay, and we had Karen Jevons. Hi, Karen. And she says the hospital environment and beds doesn't make co-bed sharing for breastfeeding safe to do.
No,
they're a bit narrow, I guess.
They're too high, they're too narrow, and the floor is too hard.
Yeah.
So,
I mean, not that. I mean, nowadays the parents don't stay, or the woman doesn't stay in the hospital environment for very long.
That's right. Yeah.
So
can I just say, when I went to Hong Kong, what they had in Hong Kong was fantastic. They had the cots, which we have also, I think, now in the UK, where it's attached to the bed, so the mother can have easy access to her baby.
Yes.
So
scoop the baby.
really an excellent way for the mother.
Yeah.
It's a fantastic way for the mother to access her baby without having to get out of bed to access her baby.
Well, that's especially for mums who've had, especially for mums who've had cesarean sections, who might have great difficulty in getting up and then pulling their babies, don't they? Okay. Yeah. I mean, is there anything? No, I was just checking. So I love the bed sharing images. Really interesting. I like the weird, and the So I mean, and I think the normality. What's underlining for me in this session is the normality of waking up and wanting to be fed and wanting to be cuddled. And I think that reinforces. And I think what was also strong for me, Helen, and I think Stephanie referred to it as well, was one using the sort of research in a much more constructive way. And maybe there's all those bits of advice to parents in the 50s and the 60s. They weren't really based on a lot of research and evidence, were they? You don't spoil the baby.
Yeah, I mean, a lot of it came from the 20s and the 30s, in that era of scientific baby care, when all of these sort of physicians and psychologists who kind of made their fortunes going around telling parents how to take care of their babies, and all of these ideas were sort of a product of that era, that children should be seen and not heard, and children shouldn't disrupt their parents' lives, and parenting was about training this compliant, self-reliant sort of individual for the future, who was going to go off and kind of become a self-made millionaire or something like that. We really sort of took them on board in the 50s and the 60s and sort of tried to follow all of these ideas. I know Truby King's idea of the baby at the bottom of the garden in the pram. My mum did that with me. I spent hours, and she was so happy to tell me that she put me at the bottom of the garden in a pram underneath a cherry tree. And wasn't it lovely that I was in the fresh air and I was under this cherry tree for hours and hours and hours, because that was what parents were told at the time. Whereas I was thinking, oh my God, I couldn't leave my baby at the bottom of the garden for hours and hours. But that was just normal in that era.
What awful things are done to make women and families kind of follow these rules, to think they're good parents and they're doing their best. So I think this what we can take away is use the research that's available, and Helen's research and Brazelton's research and the practice research we know about as midwives. It really has to be underlined, and maybe much more, just as we want to do individualized, and we talk about a lot about this, Helen. Stephanie will know, I go on about it, but doing individualized and personalized care. We need to really do individualized and personalized care for that baby as well, and help the mum to feel more confident. Because it always makes me sad when mums aren't confident, because they kind of don't realize how fantastic they are. So let's underline that. Now, I always say this is the fastest hour in the week, and it is, and it's come to an end. And I want to say a big thank you to Helen and Stephanie for joining us this evening. Now, I think we might have to have them back. I think there'll be another story in this, don't you? Just tell us if that's what you'd like. I think overwhelmingly people have been commenting. We haven't had a huge amount of questions. It's much more about they've really enjoyed the session. It's given them loads to think about, which is fabulous, what we want. So thank you to Stephanie and Helen. Also, thank you to Angelo, who's in the background, making sure this is all recorded and available for next week. Fantastic. Paul for getting the comments through to me, as he's done. And you know the resources will be available on the website and on Facebook on that podcast at 6 in the morning, and then next Tuesday it'll come through in the newsletter. So if you're registered for a newsletter, that's when you'll get it. Please do share, because I think the more we get to know this, the more we can help mums and babies and families to really grow and develop as they should be, and not be constrained, you know, down at the bottom of the garden under the cherry tree. Though, Helen, I have to say that had a lovely image for me. I could imagine you with the cherry tree. It's lovely. But it might have got a bit boring.
It wasn't very responsive, though, that cherry tree, I don't think.
Well, never mind. Anyway, so next week we'll be here in the same time, same place, and we're looking at genomics. And those of regular audience will know we've been doing quite a bit on genomics. It's very interesting stuff to know a little bit more about. And it's genomics and stillbirth, what midwives need to know and why it matters. And we've got Emma Tomlinson from Manchester University NHS Trust and Tina Prenderville from Imperial College Healthcare NHS Trust. I also am putting out a call for those of you who want a little trip to Manchester for the next festival. 8th of July, we've got fabulous speakers. We've got Mary Renfrew, Professor Mary Renfrew. We've got Patience Jumper. We've got Emma Rose from the RCM. We've got Wahid Abbas from the Northwest Genomic Medicine Service Alliance, and the lovely Dr. Catherine Gutteridge, all with us, as well as a lot of other midwives coming to speak. So you could have a little mini break in Manchester. Very good place, nice restaurants, everything. So we hope to see you there as well. And in the meantime, stay safe and well, and we'll see you next week. And thank you again to Stephanie and to Helen.
Thank you, Sue. Thank you.
Thank you very much.
Angelo.
Take care.
Bye-bye.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever.
where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is